Hernias, inguinal, both direct and indirect, versus femoral. So firstly, let's do femoral hernias versus inguinal hernias. Now, in order to understand some of this, we need to appreciate the anatomy in the area. So let's appreciate firstly the inguinal ligament. That's over here. The inguinal ligament courses from the anterior superior iliac spine down to the pubic tubercle. It's not a true ligament at all. In fact, it is a continuation of the abdominis externus, the abdominis obliquus externus. Again, polite reminder, the abdominis obliquus externus, the direction of those fibers are the same direction as you would find your hands when you place them in your pockets in your trousers. So place your hands in your trousers pockets, and the direction of your hands is essentially the direction of the fibers of the abdominis externus, obliquus externus. Okay, the inguinal ligament runs in an inferomedial direction from acis down to the pubic tubercle. The inguinal ligament also actually forms the superior border of the femoral triangle, the lateral border of which is the sartorius muscle, which runs from the acis down in an inferomedial direction and attaches to the proximal end of the tibial plateau on the medial aspect, attaching as well as with another couple of structures, of which one is a gracilis muscle, to form the pes anserine. The medial border of the femoral triangle is your adductor longus muscle. The contents of the femoral triangle are really, really important. Going from lateral to medial, there's a mnemonic, and that's navel, appreciating that the navel is somewhere up here in anatomy when you look at anatomically the umbilicus. Femoral nerve, femoral artery, femoral vein, E for empty space, and then L for lymphatic chain. Now remember, there are two lymphatic chains. You have the vertical lymphatic chain and you have the horizontal lymphatic chain. This whole thing is actually encapsulated in the femoral sheath. The lymphatic chain is found in the femoral canal. Okay, get rid of that because that's no longer needed here. We'll get rid of this here as well, and we'll get rid of this guy here. Okay, so now moving on from there, what have we got in terms of the points? So there is something called the mid-inguinal point. Now, okay, the mid-inguinal point is a midpoint from acis to the pubic symphysis. Okay, to the pubic symphysis. The mid-inguinal point is a very, very important landmark, anatomical landmark, because this is how we locate the femoral artery. When we then look at something else called the midpoint of the inguinal ligament, that is slightly lateral to the mid-inguinal point. And the midpoint of the inguinal ligament is measured as the midpoint from acis to the pubic tubercle. Why? Well, because we just said a few moments earlier that the inguinal ligament runs from acis to pubic tubercle. So the midpoint of the inguinal ligament, completely different to the mid-inguinal point. The mid-inguinal point allows us to locate the femoral artery. Midpoint of the inguinal ligament, why is that important? Well, because this is where we find the superficial, the deep inguinal ring, The deep inguinal ring is found and located in the transversus fascia. This is the deepest of the layers of the abdominal wall. Appreciate then that we have a superficial ring as well, a superficial inguinal ring. That canal, the inguinal canal, essentially runs in the same direction as the inguinal ligament, i.e. a inferomedial direction. The superficial inguinal ring is actually located in the abdominis externus obliquus muscle. Okay, that's where it's actually found. So the deep inguinal ring is found inside the transverse fascia, the superficial inguinal ring in the abdominis obliquus externus muscle. Now, when we look at hernias, we have the concept of femoral hernia and we have the concept of inguinal hernia. Now, the difference between these two is the difference essentially is relative to the pubic tubercle. Okay, relative to the pubic tubercle. In that, and the difference is such that the femoral hernias are below and lateral relative to the pubic tubercle, whereas the inguinal hernias are above and medial. Okay, this is really important. So if you look at the pubic tubercle, notice where the superficial inguinal ring is, and your inguinal hernias essentially will outpouch through the superficial inguinal ring or otherwise. However, the superficial inguinal ring is above, as you can see here, and it is medial relative to the pubic tubercle. Okay, remember this is medial, this is lateral, because your ASIS is the lateralmost part probably of the body in terms of skeletal anatomy is concerned. Then when you look at your femoral hernias, they are below and they are lateral, so anywhere in these kind of regions. Generally speaking, again, if you appreciate what I said earlier about the femoral sheath and the femoral canal, that's the area you're looking at. Okay, that was the difference between your femoral and your inguinal hernias, so we'll circle that off. Now the question is regarding your direct versus indirect hernias. So the situation really is that both of these hernias will actually protrude and emanate from the deep inguinal ring, which again, as we said, is in the transverse fascia. They will course through the inguinal canal, and your direct hernia, which actually will protrude through the superficial ring, and therefore is potentially palpable in this region here. These direct hernias, so this area through which it actually passes in the deep inguinal ring, essentially is a weaker area in this area, muscular triangular region, known as Hasselbalch's region, Hasselbalch's, and that's essentially part of the reason. So this can be acquired. This is acquired. It occurs in patients who are kind of more males than females. It's in people who are over 40 years of age. Generally speaking, it can happen in younger. Don't take me wrong, it's not confined. But predisposing factors may include excessive straining, for example, activities which will increase intra-abdominal pressure, such as weight training, excessively heavy weight training, or constipation, and therefore causing bearing down, chronic cough, for example. And then age itself, so sarcopenia in it essentially will lead to a weakening in the muscular wall and therefore potential for protrusions. Don't forget surgery and so on and so forth as well. Although surgery may lead to surgical or incisional hernias, but you get the point here. So that essentially is where we are with the direct hernias. So they'll come through the Hasselbalch's region, through the transverse fascia, course through the inguinal canal, and then protrude through the superficial inguinal ring, which is in the abdominal obliquus externus muscle. Your indirect hernias, however, are more congenital. They occur more in children, and essentially the reason they occur is not so much due to all the factors that we spoke of a few moments earlier, rather due to the persistence of a processus vaginalis. And essentially what that means is there is a bit of a route for some of the viscera perhaps to enter that processus vaginalis and then demonstrate itself as an indirect hernia. Now, in terms of clinical palpation, what you find is the exiting of your indirect hernias is actually, it'll continue from and past the superficial inguinal ring and actually protrude inferiorly. In the female, it'll go into the labia majora, and in the male, it'll go into the scrotum. Whereas, remember what we said with the direct hernia, it'll actually protrude through this region here, and that's where this whole concept of femoral versus inguinal comes in. Okay, so that inguinal generally is referring to direct hernias in that situation. So your indirect hernia will actually continue past the superficial ring and continue inferiorly into the labia majora in the female and the scrotum in the male. Clinically, it's actually, strictly speaking, quite difficult to delineate your direct from indirect hernias. It's only surgically that you can definitively delineate between these two guys. So there you are, the most important aspects of herniations with regards inguinal being direct or indirect, and inguinal versus femoral hernias. Thank you for watching.